My name's Simon Finfer, and today I'll be talking about sepsis action plans and coordinated strategies. A great deal of this will refer to the recently released clinical care standard for sepsis in Australia and to our own sepsis plans. I have no financial disclosures in relation to this talk. So I hope everyone agrees that sepsis is a significant global health challenge. The global burden of disease estimated that in 2017 there were 49 million cases of sepsis with 11 million associated deaths. That's 1 in 5 of all deaths worldwide. In addition to causing a lot of death, sepsis survivors have significant physical, cognitive and psychological problems, which can be lifelong. Sometimes they're very obvious. This is Corinne Barrett, a very unfortunate lady, but remarkable lady from Queensland in Australia, who, as you can see, is a quadruple amputee as a result of sepsis. Her health-related problems, which she makes light of and lives a fantastic life regardless, are very obvious for all to see. Less obvious may be the other physical functional disability and also long-term cognitive impairment, which may be as severe as moderate dementia, even in someone who was cognitively intact before they contracted sepsis. And unfortunately, a lot of this, both morbidity and mortality, is preventable. Around the world, it's well recognized that healthcare workers make mistakes in identifying patients with sepsis and also not treating it with the urgency and respect that it deserves until it becomes severe enough to cause people either a high risk of dying or lifelong disability. These issues have been highlighted in the UK with a Health Ombudsman's report, and Jeremy Hunt, the then Minister for Health, admitting that the National Health Service was totally inadequate at spotting sepsis. In the US, there have been a number of well-documented tragic preventable deaths from sepsis, notably that of Rory Staunton, which has led to, in his case, changing of the laws in his state of New York, and I'll say a little bit about that later. In Australia, in New South Wales, there was a clinical focus report on the recognition and management of sepsis produced by the New South Wales Clinical Excellence Commission. This was in response to analysis of adverse events, preventable death and disability occurring in our hospitals, where it was found that sepsis was the most common cause of these preventable deaths and disabilities. The World Health Assembly adopted a resolution on sepsis in 2017, and it recognised sepsis as a global health priority and laid out recommendations and suggested actions to reduce the preventable death and disability from sepsis. This gave rise in Australia to a Stopping Sepsis National Action Plan, which came out of a meeting coordinated by the then Australian Sepsis Network, now rebranded as Sepsis Australia, an organisation of healthcare workers, sepsis survivors, those bereaved by sepsis, government bodies, professional colleges, professional organisations. The key recommendations out of that included establishing a national sepsis body, investing in prevention and awareness campaigns, establishing and implementing a nationally recognised clinical standard for sepsis detection and treatment, and investing in community and peer support services for sepsis survivors and their families. A very, very important component of that was a recommendation for a clinical care standard, which was released in June of this year, June 2022, by the Australian Commission on Safety and Quality in Healthcare. Clinical care standards are not treatment guidelines. They are, I think, peculiar to the Australian healthcare system. They're a series of a limited number of high-level quality statements that are designed to ensure that all patients in Australia receive best practice care for a specific clinical condition or procedure, regardless of where they are treated in Australia. Just looking at some of those quality statements quickly, the first one is around recognising sepsis, which has no definitive diagnostic test and has a myriad of potential presentations, some of which are very atypical. And the way we have approached this is saying that a diagnosis of sepsis should be considered in any patient with an acute illness or clinical deterioration that may be due to infection. A clinical support tool that includes assessment of vital signs and lactate is used to help recognise sepsis early and escalate care when required. The clinical support tool is not mandated a particular support tool, and indeed in other countries different things may be appropriate to their particular context. So this is not saying that that is what you have to do, but it is important to have a way that you can ensure that sepsis is considered as a potential diagnosis in any acute illness presenting to the emergency department or clinical deterioration occurring in hospital that may be due to an infection. Quality Statement 2 deals with recognising sepsis as a time-critical medical emergency, and that any patient with suspected sepsis receives rapid and urgent assessment and treatment according to a locally approved clinical pathway. Again, the exact pathway is not specified, but the document contains a box 1, as shown here, essential elements of a sepsis clinical pathway. And this mirrors what it was done in New York State, where following the tragic death of Rory Staunton, a management according to a sepsis pathway was mandated in New York State hospitals, but not that every hospital used the same pathway. Clearly there are different environments, there are different hospitals in Australia. We have large tertiary referral university affiliated hospitals, we have small rural and remote base hospitals, we have Aboriginal and Torres Strait Islander healthcare facilities. All these places have different facilities, different abilities to do things, and the sepsis pathway should be tailored according to local resources. Additionally, the clinical care standard includes clinical indicators for each quality statement, and for quality statement 2, this is evidence of a locally approved sepsis clinical pathway, evidence of local arrangements that support the delivery of care described in the local sepsis clinical pathway. That's a responsibility put on the healthcare organisation. There is no point in saying that people should receive, for instance, appropriate antibiotics within a defined time window if those antibiotics are not available. And then the proportion of patients who are managed according to that approved pathway. Quality Statement 3 mirrors again the approach to antimicrobial therapy that comes from the Surviving Sepsis Campaign guidelines, the 2019-20 iteration, and calls for immediate antibiotic therapy for someone where there is a high likelihood that organ dysfunction is due to infection or the patient is shocked, and less urgent but within 3 hours for someone where it's unclear that their organ dysfunction is due to infection and there may be other causes. So it's recommended that a 3-hour period to investigate for another cause is acceptable, but should the patient become shocked or it become clear within that time period that underlying infection is the problem, then antibiotics again should be given immediately. There are two statements dealing with the fact that patients with sepsis come into the hospital and tend to be managed by clinicians based on the source of sepsis. So someone with pneumonia will be managed by a respiratory physician, someone with perforated bowel will be managed by a GI surgeon, and they may transition from the emergency department to the intensive care unit, to the ward, to the operating theatre, back to the ward, etc., etc. There are multiple transitions of care, and it's important that there is multidisciplinary coordination of care within the hospital, and that transitions of care and clinical communication are managed appropriately. The statement regarding multidisciplinary coordination of care, I think, is absolutely critical to a coordination of care. And it says that a patient with sepsis has their treatment in hospital coordinated by a clinician with expertise in managing patients with sepsis. It doesn't say a doctor, and it doesn't have to be a doctor. This might frequently be a nurse practitioner or senior nurse in our healthcare system. The importance of their role is coordination and making sure that when multiple clinical teams are involved with multiple handovers, that errors are not made during those handovers, and the person, that coordinating clinician who has expertise in managing patients with sepsis, ensures that their ongoing treatment throughout their hospital stay and indeed beyond. One of the most common complaints we get to the Australian Sepsis Network is from family members of someone with sepsis who says, nobody ever told me what was going on. So the quality standard, the clinical care standard does call for patient and carer education and information, and including expected treatment, potential health effects of sepsis, and that information is provided both verbally and in writing. This is crucial to improving patients' outcomes. The clinical care standard includes information for patients and their families, and also information for parents, carers, and families of children with sepsis. These can be adapted to local circumstances. The clinical care standard looks beyond hospital care to life after sepsis and post-sepsis care. It provides discharge planning guide for patients with sepsis, so that the system, once fully operational with a sepsis coordinator and looking beyond hospital care, will ensure that patients who currently don't get appropriate care by skilled and knowledgeable individuals after their hospital discharge do receive that care. Does this approach work? Well, we know from the original work of Anand Kumar and this second study from New York State that time to completion of bundles of care for sepsis are directly related to reduced mortality. The second paper there, the BMJ Open Quality paper, is implementation of a whole of hospital sepsis clinical pathway in a cancer hospital in Victoria, and that was by Karen Thursky and her group. The sepsis pathway was associated with a significant improvement in patient outcome and reduced costs, and this is now being rolled out across the entire state of Victoria. In New South Wales, the response to that report I referred to earlier was the Sepsis Skills program set up by the Clinical Excellence Commission, which was around early recognition and treatment of sepsis. And as you can see, this paper demonstrated a significant reduction in hospital mortality coinciding with introducing that program. So, in summary, I believe this approach works. I think the clinical care standard produced in Australia by a very large number of people working together to try and improve sepsis care can act as a good model if you're looking for such a thing. It's freely available at the Australian Commission of Safety and Quality in Healthcare, and that's their website there. If you go to that website and search sepsis, you will find the clinical care standard and other components of our national pathway. Sepsis really needs a coordinated approach and a whole of healthcare system approach. It's not an intensive care disease. It's a disease that can be managed by almost anyone in the hospital, and it's vital that this is coordinated to ensure patients get the best outcome possible.